All right, so thank you very much for the invitation. My name is Niclas Rubek, and I'm a senior consultant from Copenhagen in Denmark. I have been doing robotic surgery for more than 10 years now, and we've done quite a lot of research in both HPV cancers and robotic surgery. So the task was to set up a panel, mainly with presentations of the different trials around in the world, and also with case presentations. So the first presenter, Michiel Topf from Nashville, is going to talk a little bit about the current trials. And then we're going to do some case presentations with Samantha Hassid, who's also going to talk about the best of trial, and Nashreen will also give case presentations. And if we have more time, I also have a couple of cases, and I just wanted to shortly mention the current trials we're doing in Denmark at the moment. So I'm going to give the word to Michiel, if he's here. Yeah, you're there, Michiel?
Yeah. Good morning. Thanks so much. Thanks so much, Niclas. Yeah, and everyone see my slide okay?
Yeah, we can see you very well.
Great. Good morning, 3 o'clock in the morning here from Nashville, Tennessee, Central Time Zone in the United States. An absolute privilege to be presenting to those online and in person in Scotland. I've been tasked with going over Order ECOG 3311 and Order 2. I'm an assistant professor at Vanderbilt University Medical Center, Nashville, Tennessee, home of country music, hot chicken, and for the surgeons in the room, my boss, Dr. Jim Netterville. Just quickly looking at the patient population that we're going to look at here, we're really looking at early oropharyngeal cancer. So T1, T2 tumors, less than 4 centimeters. And many of the trials that I'm going to go over actually did not include unknown primary patients. On the right, you see one of my research interests, which is 3D scanning to improve communication between surgeons and pathologists. That's a nice example of a robotic section from last month and the 3D scan. Happy to talk more about that research in a different forum offline. The nodal disease that we're really looking at are patients with early nodal disease, so AJCC 7th edition, N1, N2A disease. And for the trials I'm going to talk about, those patients were eligible if they had N2B and N2C disease, but we're not talking about patients with large lymph nodes over 6 centimeters or matted nodes or clinical or radiographical evidence of extranodal extension. The first trial I'd like to go over is the Order trial. The Order was a phase 2 open label randomized trial. It was looking at T1, T2, N0 to N2, 7th edition oropharyngeal cancer patients. The nodes had to be less than 4 centimeters. And this was not, important to note, this was not a de-escalation trial. Okay, so this was a trial that randomized patients to 70 gray plus or minus chemotherapy, still very much considered the standard of care within the United States, towards a neck dissection with adjuvant therapy based on pathology. The primary endpoint was quality-related, swallowing-related quality of life at 1 year, measured by the MD Anderson Dysphagia Index. And the very important to note that a 10-point change was defined as clinically meaningful. And that came from, it took me a while to find this paper, but it came from a paper by Kate Hutchinson from MD Anderson, which showed that a 10-point difference in MDADI was the difference between diet levels, patients that aspirated and didn't aspirate, and patients that were feeding tube dependent and not feeding tube dependent. So that has been shown to be a relatively good marker for clinically meaningful change. Important to note that this trial actually included patients that were HPV negative. The vast majority, 88%, were HPV positive. It accrued patients from August of 2012 to June to 2017, 5 sites in Canada, 1 site in Australia. And you can see there, that's about 1.2 patients per month for 6 sites. That's not that great. And I think that kind of highlights the difficulty in enrolling patients to a clinical trial that randomizes patients to either surgery or non-surgical therapy, which is a challenge. Here are the results. You can see that the red curve is patients that receive primary radiation. The blue curve is patients that receive transoral robotic surgery. There were 34 patients per arm, so still relatively small trial. And at 1 year, the patients that received radiation actually had higher MDADI scores, and that was statistically significant, but it was not a clinically meaningful change based on the predetermined quality of life outcomes. So the difference was about 6.7, not 10 on the MDADI. And a more recent follow-up paper with long-term data published in JCO this past year shows that that difference is significant at later time points, 2, 3, and 4 years. However, that difference decreases with time, and the curves come together a bit. And you know, the conclusion from this first paper, and I don't necessarily agree with it, was that these findings that suggest that TORS should not be favored over radiation therapy, and that the widespread adoption of transoral robotic surgery in some jurisdictions was premature. And for the Game of Thrones fans out there, perhaps we should have never left Winterfell in the first place. I realize that not many people probably know who this is here. This is American football analyst, but you know, I have a few critiques and comments on the order trial. The first is that it included N2 patients based on the 7th edition, and N2 patients is, you know, an N2A, you know, patient is very different than an N2C patient. And you're looking at patients that, you know, some of which may be able to get single modality, but many of which are going to definitely need bimodality or trimodality therapy. The other thing that we'll mention in order 2 is that the trial was set up that the surgeons were supposed to be going for 1 centimeter margins, and we know that this is probably not necessary, and that 2 millimeters, particularly in the deep aspect of the tonsil, is likely adequate in HPV, low risk HPV positive oropharyngeal cancer. MDADI is reported up to 3.5 years, but that certainly doesn't account for late rad, and I would argue that any radiation you can spare your patients is worthwhile. I'm seeing patients in my clinic every week now treated in 2008, 2009, 2012 for a tonsil cancer, base of tongue cancer, that are now starting to have issues with late effects of radiation. And then the other thing that significantly can impact quality of life is that tracheostomy was strongly recommended in these patients after early death on the surgical arm, despite these patients having T1 and T2 tumors. And 18 of the 34 patients, this data is available in the supplement, were actually received a tracheostomy, and we know that that is certainly not the standard of care within the United States for TORS, and tracheostomy, even in the perioperative period, could certainly affect long-term quality of life. Moving on to ECOG 3311, which was briefly mentioned earlier, this is Dr. Bob Ferris' trial. This was a trial within the United States that accrued patients from 2013, late 13 to mid 17. 68 credentialed surgeons performed 495 transoral surgery procedures, the vast majority of which, 89%, were transoral robotic surgery, but TLM was allowed as well. And what this trial set out to do was randomize enroll patients with early stage tonsil cancer, P16 and base of tongue cancer, P16 positive, that did not have matted nodes and were accessible via transoral approach. And then after transoral resection, neck dissection, and transcervical arterial ligation of external carotid, the patients were risk stratified based on pathology. So low risk patients with negative margins and N0 or N1 7th edition disease went on to observation, and then intermediate risk patients, and this is the group that was really being investigated. Those are patients with clear close margins, so less than 3 millimeters, minimal E&E, 1 millimeter or less, 2 to 4 metastatic lymph nodes, PNI or LVI, were randomized to either 50 gray or 60 gray of adjuvant radiation. And then the high-risk patients, those with positive margins, 2 millimeters or greater extranodal extension, or more than 5 lymph nodes, went on to receive radiation at 66 gray with chemotherapy. The primary endpoint of this trial was 2-year progression-free survival, and specifically looking at that intermediate risk population. Here's the data from the published in JCO this past summer. You can see the 2-year PFS rates there. Arm A, no radiation, adjuvant radiation, 96.9%, and then the 50 gray versus 60 gray, 94.9 versus 96%. And then even the high-risk patients that did receive triple modality therapy still did quite well with a 2-year PFS of 90.7%. So, the conclusion from the authors of this paper was that primary transoral surgery and reduced postoperative radiation to 50 gray resulted in outstanding oncologic outcomes and favorable functional outcomes in intermediate risk HPV-positive oropharynx cancer. If I'm going to be critical of this study, I just point out that 31% of the patients did receive triple modality therapy. That's Arm D. So a lot of patients are getting radiation and chemo after surgery based on these inclusion criteria. And that number was 44% for patients with clinical N2B disease. So when I see that, I really pause when I'm evaluating a patient in clinic with more than one lymph node, because there is a almost 50% chance that based on the criteria for ECOG 3311, that patient would require triple modality therapy. And finally, I'd like to cover Order 2. This is another de-escalation trial, similar to 3311, that randomized T1, T2, N0, N2, 8th edition HPV positive only patients to 60 gray with cisplatin, plus or minus cisplatin, based on a trial called NRG HN002, or TORS and neck dissection with adjuvant therapy to 50 gray, similar to the ECOG 3311 intermediate risk group, in a 1-to-1 fashion. And the primary endpoint was overall survival compared separately for each arm to historical control. As many people in the audience know, this actually accrued from February 2018 to November 2020, and the trial was terminated. 9 sites in Canada and 1 in Australia. And in Australia, similar to the initial Order trial, 61 patients were randomized, 30 to the RT arm, 31 to the TORS and neck dissection arm, with 27 ultimately receiving transoral robotic surgery. And the trial was terminated early because of 2 treatment-related deaths in the TORS arm, transoral surgery arm. Both patients did undergo transoral robotic surgery. The first was a basic tongue primary patient who died of oropharyngeal hemorrhage on day 4 while in the hospital with a trach despite having external carotid artery ligation. The second was a tonsil primary that died of cervical vertebral osteomyelitis, which is a very rare complication following robotic surgery, 1 month following adjuvant radiation. The authors concluded in this randomized clinical trial, transoral surgery was associated with an unacceptable risk of grade 5 toxic events, but patients in both trial arms achieved good swallowing outcomes at 1 year. I do have a little bit of an issue with this trial. Again, the 1 centimeter margins, I think, is a bit much for low risk HPV disease. Are they having more bleeds because they're taking too much tissue? Obviously, this is low sample size. So those 2 grade 5 treatment related deaths, are going to be magnified when there's only 31 patients in the treatment arm and 27 that received surgery. And despite them using a very similar credentialing process to the ECOG 3311, you do have to call into question the surgical quality when you kind of objectively look at the data. I made this figure here on the left, this pictograph of the 61 patients that received surgery on Order and Order 2. There were 3 treatment-related deaths for a grade 5 toxicity rate of 4.9%. In comparison, ECOG 3311, 495 participants, 1 death, 0.2%. Future trials really probably should start with patient selection rather than clinical staging. Start with patients that are favorable for TORS. It's more than just clinical stage. Not every single T1 or T2 patient is a good TORS candidate. And my mentors who trained me, Chris Holzinger from Stanford, Dave Cognetti from Jefferson, have always emphasized that. This is a trial we're about to open at Vanderbilt. It's open at Winship Cancer Center at Emory in Atlanta, down the road from us. It's taking low-risk HPV positive patients, having them undergo tours, and then afterwards, patients. So the patients are enrolled after robotic resection. We're checking circulating tumor HPV DNA on them pre-op. If negative post-op, we're going to de-escalate to 36 gray without chemo. And if still positive, we'll treat to the standard of care treatment per ECOG 3311, which is the 50 gray in the adjuvant setting. So a lot of these type of phase 2 trials are going to be popping up in the United States and across the world. And I think it's a really exciting time to be taking care of HPV positive oropharyngeal cancer patients. Sorry that I couldn't be there in person. That's my daughter, Madeline. She was born 3 weeks ago. But would like to invite all of you. The American Academy of Otolaryngology is headed to Nashville, Music City, USA for the first time next year. We are gonna, myself and my partner, Dr. Kyle Mannion, are gonna be hosting a pre-course Vanderbilt 2023 Head and Neck Cancer update the day before Academy starts, the Friday before, and would love to have you all in attendance and at the meeting. There's my email for any questions, and I thank you for the opportunity to present.
Okay, thank you very much. I don't see any questions at the moment. Do any of the audience have any questions? All right, so I think we're going to continue with Samantha's case presentation and a presentation of the best of trial.
We will move with our case presentation and work a little with the panel. So this is a woman of 77 years old, and she had just an history of breast cancer and no other history. And she come from us for pain inside the moles on the right side. We see a little tumor, and we make some investigation, PET-CT, panendoscopy, and MRI.
Yeah, that looks right.
You see that?
Yeah. Perfect.
So this is a PET-CT. You see the right tumor. It's 26 and 29 and 18 millimeters with a really small tongue invasion. There are no, we doing an MRI for the paropharyngeal space, which are not invaded, and there are no lymph nodes associated. So we have classified it like CT2 N0 M0. Next. Yes, this is the MRI. So we see the tumor. So what's the panel purpose for the management of this patient? Niclas, what do you propose for him?
So can we see the MRI on the possible invasion of the tongue base?
The little small invasion of the tongue base.
So is it into the intrinsic tongue musculature?
I don't know how to do to stop it. Yeah, sorry. Maybe in this slide we see better. So they're just a little invasion here. Yeah. But not so much.
Samantha, can I ask, when you're examining the patient in clinic, is the tonsil cancer mobile?
Yes.
Good point.
Is it possible to get a biopsy in the clinic itself, or because we haven't got any histological diagnosis yet?
Sorry?
We haven't got any histological diagnosis yet.
Yes,
so you could get a biopsy in the clinic itself if the patient allows you to. or list the patient for an examination under anesthetic and get a biopsy, and you'll be able to get good assessment of the mobility. But some patients do tolerate an examination in clinic, and you could assess all of these in clinic itself. Thank you.
Yes, she did the panendoscopy and biopsy, and it's a squamous cell carcinoma HPV positive. A little too smooth, but it's okay for doing tours. Okay, so we make the tumor board meeting, and we propose two possibility, whether radiotherapy or TORS management. So we perform a TORS management for these patients. So this is the tumor, you see here before the surgery and the bed size after the surgery. The specimen is there. We make some fresh frozen section during the surgery, and all are negative. And we put a feeding tube for some days. And after that, we management the neck. In our center, we are the habits to manage in zero by sentinel lymph nodes. So we had the tumor here. We put with a local anesthesia 4 pounds injection around the tumor, and we see the drainage in the SPECT CT. And after that, we have a little sound to check the neck during the surgery. So we first begin with the TOS management of the tumor, and after that, we make the sentinel lymph node in the same day. So all is done. And this is the definitive histological results. So we have a squamous cell carcinoma pieces positive, and the size is a little bigger than expected, with 45 millimeters for the big diameter. And we have a left margin close on the final histology. But all the cutting during the fresh frozen section are free of disease. And about the sentinel lymph node, we have 3 sentinel lymph nodes, 2 in the right side where it's positive, 1 in the left side is negative, and 3 of the non-sentinel lymph nodes was also removed, and they are not invaded. So there are 2 positive lymph nodes in the right side with maximum 5 millimeter invasion inside. So with this kind of histopathological result, what the panel propose? What do you do?
So I understand you correctly. There's no sign of extranodal extension, right?
Yes.
Okay.
No sign of extranodal extension.
So the tumor is larger than a T2. So we would probably discuss whether or not the patient should have post-operative radiation. But in this case, if you get free margins, did you take supplementary margins or frozen section margins during surgery? So you had free supplementary margins. So I guess the 1 millimeter margin that was below 1 millimeter, is that like the definitive margin, or was there a supplementary free margin from that?
So for us, the definitive margin was close, less than 1 millimeter.
Okay, so I think we would probably recommend post-operative radiation for this patient. I don't know what the other panelists.
Yeah, can I comment? Yeah, because first of all, the frozen section is of course always difficult if that's really on the right place. So we would then still look probably at the closed margin. But the other issue is, of course, you have done not really a selective neck dissection. So you did like a lymph node picking with the sentinel nodes. So, and they are 2 positive. So I think there is now the choice, in fact, first to do a complementary neck dissection, complete neck dissection, or go to radiotherapy right away. I don't think there is any evidence what is better in the literature. My gut feeling says it's probably very similar because there were small metastases. So, and she's already quite old, 77. So I think she needs adjuvant radiotherapy. Yeah.
And then,
Sorry if I missed it. Can you go over the smoking status of the patient?
she's a non-smoker.
Sorry?
She didn't smoke.
Non smoker. No. Why do you think it's important, Michael? What would it influence you or?
Probably not in this particular case, but I always, I think the data is there from the Ng paper, New England Journal, to suggest patients with 10 pack year lifetime or greater are truly not low risk. They're more intermediate risk patients, and that does, in my opinion, factor in for some treatment decision. Perhaps not for this particular case, but always good to know smoking status.
And my question would be also, let's say that the notes would have been negative, huh? And then with this close margin, because I think that's because with these notes, it makes it easier that she needs adjuvant treatment. But very often they are negative, of course. And then you have always this big discussion with a small margin, 1 millimeter, and then your extras, frozen sections in the tumor bed are negative. Do people feel comfortable not to radiate these patients? So, because I know from all this trial that you just showed is that this TORS really has big advantage, of course, if you don't have to radiate. And if you do have to radiate post-operatively, then there will not be a lot of improved quality of life for these patients. So what is your opinion on that? If you have these margins of 1 millimeter and the frozen sections are negative, are people confident enough not to radiate these patients?
Sam, can I come back on this?
Yeah.
Thanks, panel. My name is Vin Pelleri. I'm a head and neck surgeon. This is a really awkward place to be in for patients, for MDTs, for surgeons looking after these patients. It's one of the worst scenarios where you offer them surgery and then you're in a position with that margin of being forced to almost give them concurrent chemotherapy with radiation therapy. And this is why I think case selection is important. And if we are, that's a large T2 at the end of the day. It's not a small T2 at all on the larger side. If we are performing robotic surgery for these particular patients, they should be under a trial envelope. I'd feel so guilty seeing these margins, because going back and taking a frozen section, that just doesn't cut it to the MDT. If you have a really sharp oncologist sitting there, Silke is shaking her head, I'd feel really guilty presenting this patient. We have to get these patients into a trial envelope. Otherwise, I don't think an MDT should be offering T2 N0 patients transvaal robotic surgery, because they get CRT. And the patients who get CRT after primary TORS, I've seen some pretty radical complications in the long term too.
Mm.
I would also supplement and say that when looking at the clinical photos and not having my finger inside the actual mouth of the patient, it does look like it's not a T2 from the images. And I expect that it would probably be adhered to the around the mandible or the pterygoid muscle. I'm not sure, of course, but it does look quite big. So I think it's a difficult case, and if you have an option to do primary radiation on a patient like that, I would probably opt for that, unless the patient had radiation before.
Yeah,
I agree with Niclas there. I would probably, for this, I'm conservative in my patient selection, but I probably would have elected for a primary non-surgical approach. In the current situation, I would probably, I don't do sentinel lymph node for oropharyngeal cancer, but at this point, I would probably go straight to radiation therapy. In this patient with low risk HPV disease, I'm not sure about the addition of adjuvant chemotherapy for a close margin. When you look at some of the data from RTOG 9501 in the European trial, and you look at that and that cohort of patients, many of those patients weren't HPV positive. number one, and very few, less than 10% of those patients had positive margins alone as a risk factor for chemotherapy. So in the absence of extranodal extension, I'd probably go straight to radiation therapy in this particular case.
Yes.
One more comment. She's 77, so concurrent chemotherapy is out of the game completely, because we know from the meta-analysis patients beyond 70 don't benefit from adjuvant combined therapy. The benefit decreases with age 65 and it's basically with 70 not existing anymore. So I totally agree with what has been said. So we're in a mess here right now, so we have to make the best out of it. As a radiation oncologist, I have a question to the surgeons. What is the evidence of sentinel nodes on oropharyngeal cancer? I know it's established in early oral cavity cancer, but I'm not aware. I mean, coming from Germany, I don't think anybody does that outside of a trial. Sentinel and oropharyngeal. No, we wouldn't do that. I've never heard of this, really. Thank you. So
it's not
sitting in
routine.
MTD
There's
with
no
this
public data
patient,
on that. No.
as a radiation oncologist, I would say she's got to have a complete neck dissection, and since she has 2 nodes already, you even would think about, with this big primary tumor, you do the contralateral side. I'm a fan staying unilaterally, but here we have, it's between sitting in a rock and a hard place, right? So I would vote for complete neck dissection, diagnostically and therapeutically, and then I, as a radiation oncologist, know which level do I have to treat to what dose. Mm-hmm. So that would be very important for me to achieve good local control for this patient.
Yeah, and what we did. So
maybe nice addiction. Can I add a little bit? A nice study that we are doing currently is patients who are treated with radiotherapy or chemoradiation for oropharynx. We do a kind of sentinel node, just a detection with the scintigraphy before the radiotherapy. So the radiotherapist is guided which levels to include, and almost all people get unilateral radiotherapy because but it's in a trial, of course, because it's if there is unilateral drainage of the lymph nodes, then they get unilateral radiotherapy as well.
I think we have Johan, you have joined us. I think that would be great to hear your points, because I know radiotherapy is not always an option everywhere. So how would you handle a patient like this?
My apologies for being late. I'm in New York,
problem.
and it's just after 4 o'clock in the morning. Yeah, and so yes, perhaps I've been put here, I think perhaps just to bring some sanity to this panel, because you are speaking to a worldwide audience, and just to be reminded that 70% of head and neck cancers occur in developing countries, and half the countries in Africa don't have radiation therapy. And very few countries have robotic surgery. I mean, we don't image all our patients preoperatively because we even in Cape Town, because we can't do so. It simply isn't an option for most countries in the world, and even getting a P16 isn't possible in most countries in the world as well. So it just creates this whole challenge about how we this discussion to most parts of the world, really. So really what we have is really use our clinical assessment of the patient, and we do transoral surgery wherever we can, but we mustn't forget also of our suprahyoid and our lateral pharyngotomy and our mandibular split approaches, which are still used quite widely. And also this creates this challenge about how we develop our staging protocols. And with AJCC and the UICC staging, which incorporates P16, simply isn't relevant for most of the world. It can't be done. And so we are moving in very different directions. And so really that's my comment, is that the way that you practice your approach to the oropharynx just isn't applicable in most of the world as we see it at the moment.
Thank you. For this patient, I'm totally agreed. It's not a good scenario that we don't want to have with surgery for the prognosis. And and that. And so move forward of this patient, we decide to come back to the OR to take another cutting on the bed resection and to perform the neck dissection, because there are two sentinel lymph nodes invaded. Yes, we performed the sentinel lymph node for the oral cavity and the oropharyngeal cavity, and we have some trials to in ongoing for testing for the supraglottic also subsites. But there are some article in the literature to perform it in the oral cavity and oropharyngeal space also. And so so yes, we did perform the neck dissection, and this is the finally histological results. In the resection that we perform on the bed resection of the tumor, there are no evidence of isolated tumor cells. We didn't see any tumors. And about the neck dissection, we don't have another metastasis. There are only 2 lymph nodes invaded in the sentinel lymph node, but not in the neck dissection. So the final classification was PT3N1. So there are any comments of the audience about this?
So this is a very interesting case. I mean, this is T3N2B on TNM7, and now certainly in our institution, it'd be very difficult to argue that's the end of the treatment line for this patient. What's really my question is more for yourself and the panel is the future trial data going to show the weighting of small 2 nodes under 1 centimeter and close margin, the importance of close margins? Because actually how we weight those 2 factors, I'm not sure that the trial data is going to provide us the information for that, because at the moment they go into arms B or C in pathos or best of. So that's just a kind of question and comment. And the final thing is, another factor that depends on the patient's outcome is how well they are after the first surgery. If they're in loads of pain and can't swallow, you say, oh, I'm going to do another operation on you now, and you're going to have radiotherapy after that. The patients might start to think, hang on, what's going on here? Whereas if the patients do really well functionally after the surgery and they're up and about and eating and drinking, then they're quite happy if you're telling them that further surgery is going to avoid radiotherapy. So what I'm saying is quite hard to kind of argue that any further surgery is going to avoid radiotherapy in this T3N2B stage 3-4 cancer.
Okay, so
Yep.
Sam, I have a question for the panel.
Yeah, maybe one adjunct. So in fact, now you've done the worst thing, because you did 1 surgery, another surgery, and radiotherapy. And with only radiotherapy, this will probably also have been right. So I think it's important to realize this, that we have good radiotherapy, at least in the Western world. In Africa, probably you have to do this surgery because there is no radiotherapy. But then you also don't do this transorally because your margins, it's so difficult to get very good margins in these T3 cases. Yeah.
I have a question to the panel and perhaps to people in the audience who are expert members of the head and neck fraternity. Following on from what JP said, given the publication of the ECOG 3311 and the NRG-HN002 indicating surgical and oncological de-escalation, what are the practice implications, especially in the US where both papers came from? So how are we, I know that the ECOG 3311, Michiel, great talk earlier, is not going to go into a phase 3, we know that. NRG-HN002, I don't know, I haven't heard anything was going to a phase 3. So what next in terms of de-escalation?
I'll just comment that 002 did sort of go to phase 3, and that's NRG-HN005, which is randomizing patients in 3 arms, 70 gray cis standard of care, 60 gray cis arm 2, and the third arm is 60 gray with nivolumab, which members of the community are perhaps a little bit less excited about given some of the recent results in immunotherapy for head and neck cancer.
think it's a good case.
60 for the intermediate group from ECOG 3311. How are we taking that forward?
This patient I would have been an unknown in ECOG 3311, I believe, because of the T3 status, albeit barely T3. So I'm not sure this patient would have qualified for arm B or C in ECOG 3311. That being said, for this one, I can maybe convince my radiation oncologist to de-escalate to 50 gray, but probably going to get 60 gray adjuvant radiation. I'll add that that's still less than 70 gray of primary radiation.
Yeah, I think also it's a good case to try the de-escalation.
But the standard of care is 60 gray in a postoperative setting, as long as there's no phase T3 data. And since the trial won't go in a phase 3, so we'll never know, I guess, until the Pathos trial comes out.
Yes.
And the Pathos trial is very difficult because from the recruitment, because it excludes patients with N2B who have smoked prior to diagnosis. That's the reason why we fail to put patients in, because every patient would ideally they all have smoked. Germany is still a smoking country, unfortunately.
Yeah.
So we'll have to wait until then. It's 60 gray.
At this moment, we perform also adjuvant radiotherapy with 68 degree because we need to
68 degree.
66. Yeah.
66. Why? Because of the close margin situation there.
Yes.
See, I wouldn't do that.
Yeah.
Because
So
you
for
did
this moment,
double
but I think
surgery.
it's a good case to put in a trial and to start with this escalation. So I will see with the next years with the next results for the desescalation trial.
Because the risk of dysphagia after 66 is again higher than you give 60 gray, because the muscles don't want to see more than 55, and it's very difficult to get when you have oropharyngeal cancer.
All right, so I think we should continue to the best of
yeah, this is
presentation.
Brekel, and this is another. Maybe can I?
Nick, could I just make a quick point? In the United States, many cancer centers, mine included, now consider, based on it is phase 2 data, but we'll never have phase 3 data, 50 gray in the adjuvant setting, standard of care for intermediate risk patients. So based on the publication from this summer, my patients now get 50 gray in the adjuvant setting if they were going to be a candidate for 3311. And that's many cancer centers within the United States.
Michael, can I come back on that? That's I'm sorry to be so controversial, but that's exactly what happened with the ECOG 1308 when we used cetuximab and then de-escalate, and RTOG 1016 showed something different. We've learned hard lessons from implementing phase 2 data outcomes. How does your MDT deal with that dissonance? I'm trying to get into the head of your multidisciplinary team. Based on that phase 2 data, how do you accept that dissonance that phase 2 doesn't always translate into phase 3 outcomes?
It's a great question. It doesn't. You're completely right, but I think it's just an overall kind of gestalt that realistically we're overtreating many of these patients, and the toxicity of the radiation, and you know, a lot of these patients are in their 40s, 50s, and have to deal with the late effects of the radiation for decades. And we're seeing the patients that were treated in the early 2010s and late 2000s that do well for 10 years, and they come back and they have late effects of radiation-related malignancies, late dysphagia. So I think when those patients come back, it makes you think about perhaps treating on phase 2 data, because you know that phase 2 trial is probably not going to happen from a logistic standpoint. But you bring up a very, very good point.
Niclas, you got 14 minutes for this panel.
Okay, so we'll have to continue.
So just to present the best of trial, this is an European trial by Professor Christian Simon, Switzerland, and they compared the best of radiotherapy like EMRT with organ preserving. And the best of surgery, it can be TLM or TORS. And they include patients with T1, T2, N0 in 1 oropharyngeal, but also supraglottic carcinoma and T1, N0 hypopharyngeal carcinoma. And there are randomization between the surgical group and the radiotherapy groups. They want to include 1 and 12 patients. It's still ongoing. And the endpoint is a little like Orator with the MDID score at 4.5 months and 12 months. But there are some difference by Orator. It's about the inclusion of the N0 in 1. They expect to have less adjuvant therapy like this. And they also recommend no tracheostomy for the surgical group if it's not necessary. So it's some difference. And there are also secondary endpoints like oncological outcomes, functional with fees and feeding tube using, and quality of life, of course. So it's still ongoing. We will see in the next month what's happened about this. Yes.
I just have one question, and thank you very much for a good presentation and also the cases. How many have you recruited so far in the best of trial? Is that confidential?
I think it's for this moment 50 patients. I'm not sure.
Okay. And next case presentation is Nashreen.
Lovely. Thank you very much. Good morning. A real privilege to be part of this panel today. We've talked about some published and ongoing de-escalation studies today and what their current and future impact are going to be on our clinical and future practice. So I'm going to present one case. Is that moving? Yeah, okay, lovely. And that's simply to illustrate a couple of the trials that my unit have enrolled patients in. So we've got Mr. A, who's a 58-year-old non-smoker, good performance status, with an incidentally found 3.5 centimeter left level 2A neck lump, presenting in the rapid access neck lump clinic on the NHS 2-week rate pathway. He did not have any other symptoms suggestive of head and neck cancer, and he also did not have any symptoms suggestive of lymphoma. And as you can see on this video, if it's projecting, there is a lesion in the left base of tongue. So in the interest of time, I'm not going to ask the panelists how they're going to investigate this patient. So according to the UK multidisciplinary guidelines of 2016, it's recommended to get a CT scan to look at the neck and the chest for lung metastasis and look at the nodal basins, as well as an MRI scan for accurately staging the primary lesion. So on this T1 post-contrast fat-sapped MRI image, you can clearly see a focus of abnormal enhancement in the left base of tongue. It's localized to the base of tongue itself. It's not going into the extrinsic muscles of the tongue. And you also can notice on the contralateral base of tongue, the normal striated enhancement pattern of the rest of the lingual tonsils. So if we're thinking about curative treatment, a biopsy is mandatory. And we've mentioned this before, either if you can get a biopsy in the clinic itself, or if you are going to get an EUA of the patient, that will be really helpful in terms of assessment of the primary lesion, the resectability as well, because sometimes patients don't really allow you to have a good feel of the base of tongue in the clinic. So this rapid sequence of investigation allows me to be able to give my patient a diagnosis within the NHS 28-day referral to diagnosis pathway. He was diagnosed with a T2 N2B M0 HPV positive left base of tongue, HPV positive cancer, which on the previous CNM classification would be a stage 4A, but on the current classification, it's a stage 1 disease. So we look at different factors to guide our decision-making during our MDT discussion, which happens on a weekly basis. And perhaps I'm going to stop there and ask the panelists, how do they feel that they would treat this patient? Can I ask Niclas, perhaps?
Absolutely. So a T2 N2B, we would during the MDT, the patient would be offered primary chemo radiation following the Danish DAHANGA guidelines. So we don't offer any patients primary surgery above N1.
Lovely, thank you. So in the UK, chemoradiotherapy has been the standard care for oropharyngeal cancer for decades, but with HPV viruses, the HPV epidemic, and the increased number of patients presenting very early, young, fit, non-smoking patients who have very long to live with the side effects of chemoradiotherapy, in our practice, we have started to move towards minimally invasive surgical management with either laser resection, if access is good, or preferably robotic surgery with neck dissection. Given that this is a midline organ in the base of tongue, a bilateral neck dissection would be recommended. And we've been doing risk stratified de-escalation within clinical trials, and that's as recommended by the National Institute of Clinical Excellence, as well as the multidisciplinary guidelines of 2016. Outside clinical trials, it's not recommended to de-escalate patients' treatment because none of us really want to be on the BBC News. So if I could very briefly mention the PATHOS clinical trial, essentially this trial opened in 2015 and is still ongoing. The aim is to recruit about 1,082 patients and is due to be completed in 2026. The aim of the trial, similar to previous ones that we've discussed, is to look at de-escalating adjuvant treatment after patients have had transoral surgery for HPV positive non-smokers and ex-smokers. So these are people who've stopped smoking over 6 months before. And we're looking at whether this de-escalation is going to give equal high cure rates in these patients who would have previously been treated with chemoradiotherapy, whilst improving their swallowing function as well. So after the surgery, the patients are risk stratified into 3 groups. The low risk group, which are the patients who do not have any adverse features on their pathology at all, would not get any form of adjuvant treatment and would be followed up according to the NHS and the head and neck guidelines for 5 years. And they would still be getting their measures done similar to the other groups. In the intermediate groups, the patients who are T3, so Samantha, your patient would probably have been in the intermediate risk group, group B, if he were enrolled in the PATHOS trial. And it also includes patients who have N2A, N2B disease, perineural invasion, lymphovascular invasion, and margins between 1 to 5 millimeters. So these patients would then be randomized into 2 groups, 60 grays, or reduce the radiotherapy by 10 grays into group B. The third group of patients is the high risk group, and that would involve patients who have had involved margins less than 1 millimeter with negative marginal biopsies, or evidence of extracapsular or extranodal extension. So these patients would then be randomized into 60 grays with cisplatin, which is the standard treatment, or given just radiotherapy without chemotherapy. the primary endpoint of this study is looking at overall survival and swallowing function at 12 months. There are a number of secondary outcomes as well, which include acute late-stage toxicity, disease-free survival, local regional control, and the presence of distant metastasis. So in this patient, I did a bilateral selective neck. I also did a ligated his ipsilateral lingual artery, and I have done a robotic left base of tongue hemiglossectomy using the Da Vinci robot. This is the pathology, and if I could ask a couple of the panelists what their thoughts are. So we've got a completely excised tumor, 2.3 centimeters by 1.1, and the mucosal and deep margins are both clear, 3 millimeters, but 3 out of the 29 ipsilateral lymph nodes were involved with microscopic extranodal extension. Michiel, can I ask your opinion about this? How would you proceed?
Yeah, thank you. Yeah, also interesting case. Yeah, because the patient is in the trial, probably, then the trial, you don't have to think too much anymore. So you can, but if we would have treated, well, first of all, yeah, we like Niclas said, patients with such extensive neck disease, in our cases, we would never start with transoral resection, so they would just go for chemoradiation. But in this postoperative setting with microscopic extranodal spread, well, there is of course discussion if how much microscopic spread is important for the prognosis. We certainly know that macroscopic spread is very important, so then they would certainly get chemoradiation. If it's really minimal microscopic spread and it's just 2 nodes and the margins are clear, we might think about normal postoperative radiotherapy, but probably this patient would go for postoperative chemoradiation. Yeah, it's because there is extranodal spread. And even if it's microscopic and it's in 2 nodes and they were quite bulky, these nodes. So we would, by our, in our MDT, decide for chemoradiation postoperative. Yeah.
So
Lovely.
I would like to supplement just we are a little pressed for time, but so we've had a lot of problems with extracapsular extension, and we always stage the neck before surgery, before transoral surgery, because if they fail on the neck with ECE, we will send them to get radiation anyways. So we try to avoid triple modality therapy, especially for the oropharynx. So staging the neck will prevent you from getting into having to offer the patient triple modality therapy, and that's experience from our prior trials as well.
Thank you. I mean, this patient is in a clinical trial, but if we look at previous reviews, such as the Bernier paper from 2005, it favors the use of chemoradiotherapy in ENE and positive margins, whilst there's been other retrospective data not really showing a survival advantage with postoperative chemoradiotherapy over postoperative radiotherapy. Plus, you've got the mortality rate associated with giving patients chemotherapy as well. If we actually look at those studies in that paper, they were carried out over 2 decades ago. They're not really specific to oropharyngeal cancers. They included multiple sites. And to be honest, if we look at the cohort of patients back then, the percentage of the oropharyngeal cancers who would have been HPV positive would have been less than 10 to 15%. So I don't think the results of these studies are really applicable to what our current study populations are like. So my personal opinion, and I'm sure a lot of people will share this in the audience, or there'll be lots of people not agreeing, is that ECS in HPV positive squamous cell cancer who are surgically treated is a really poor predictor of disease recurrence. So does the PATHOS clinical trial actually address ENE? Yes, it does in a certain way. Those patients will end up in group C, which is the high risk group, and randomized with chemoradiotherapy versus just radiotherapy. But I just don't think that the trial has been designed and to be sensitive enough to differentiate between different types of ECS. And the ECOG trial is probably a tiny bit better designed in that sort of scenario, because if we're looking at my current patient with an ECS of less than 1 millimeter, he would fall into the intermediate category instead of the high risk category. And in ECOG, the patient would have received simply radiotherapy and de-escalated radiotherapy as well, showing really good survival, 2-year progression-free survival of up to about 95%, similar in both groups. So
Niclas,
Yeah,
you want to
I
take
think
questions for 2 minutes, then
yes, I think we should do that. Yeah.
okay.
Thanks.
So
Could I ask a quick question? When is the accrual estimated to be complete for the Pathos trial?
It's supposed to be around 2026. So there's still a few years to wait for these results.
Thank you.
Can I just make a quick comment? There is a big debate about how important is the extranodal extension HPV-related oropharyngeal cancer. There's some phase 2 data which they de-escalated treatment and disqualified it as a high-risk factor, which seems to be very promising, but there's no phase 3 data, and I'm not sure where we ever get them. So we distinguish also, if it's less than 1 millimeter, we would just kind of ignore the extranodal extension, and it's always good for the pathologist to really say how much extranodal extension there actually is. It's a difference if it's like widely arranged over the whole lymph node, or it's just a focus. So I totally agree with you. I would probably put this patient in the intermediate risk group as well.
So I think we're gonna come into actually there's a lot more on Pathos later today. So maybe we could, if there are any more questions in regards to Pathos, maybe we should save it for that talk. I think, are we out of time, or do we have time for more?
I think you can take 2 minutes, please.
Yeah. All right. Okay. 2 minutes. So any other questions?
Check the Q&A. There may be some questions.
Yeah. So
online.
there are, I think there are old questions from
Maybe
earlier.
then I have one comment about the extranodal spread. I once did a study, it was published, looking at this small extranodal spread. And in fact, if you ask the 10 pathologists to look at it, they hardly ever agree. So the kappa value was quite low, around 0.6, I think, for these small extranodal spreads. So also for pathologists, it's very, very difficult to really make this diagnosis.
Mm-hmm.
I think the question is the weighting, the importance of adjuvant treatments in the different groups, low, intermediate, and high. What is the additional survival benefit of the different adjuvant treatments? So we expect a certain survival for an intermediate group, HPV positive, that like this case is likely to do very well, 5-year survival. And what is going to be the additional survival benefit of adding radiotherapy in terms for the patient's 5-year survival? I think that's a really important thing to say to, and I think that's what we need the answer for. This additional treatment of 60 Gray will give you this 5-year survival advantage compared to 50 Gray or no radiotherapy. I think that's quite an important number patients would want to know.
I also think that it's very important. Now, we've talked about 2 cases where I wouldn't have done surgery on any of these. So unfortunately, we haven't really presented one of more simple cases, and we don't have time for that. But I think patient selection is the most important thing. I mean, we are trying to offer robotic surgery as a single modality treatment. Of course, there might be it might be necessary to do post-operative treatment as well, but trying to select your patients and going about it in a systematical way, doing staging of the neck before, so you're sure you don't have to do radiation of the oropharynx afterwards, is extremely important. And that's also maybe why these early stage trials are pretty slow in recruiting patients, because there are not a lot of these patients. But I think that's the primary role of surgical treatment, as long as we don't have any numbers that support that you can not give the patients post-operative therapy. Yeah.
just one more comment. Since you quoted the old adjuvant trials, the EORTC and RTOG trial published first time in 2004. So the late update of the Cooper trial, the RTOG data, basically in 2012, I think it was, they showed that the initially reported survival benefit was completely gone. And the only benefit there was the local regional control. And that, in fact, the people or patients who received adjuvant chemo-RT had a worse survival in the long-term follow-up. So we do have to consider that.
Okay.
Any more comments?
The curves will always come together, as you know, some of the patients with early deaths, then the curves are going to come together with time to that point with the long-term data from 9501 and the European trial.
Michael, could I just comment, just to back up what's been said by Michiel and others, is I think our biggest challenge, and and this is what applies especially in poorer countries, is to avoid triple modality treatment, because obviously that's far more stark in a situation where you can't give supportive care in terms of pig feeds, etc. And I think some of our concerns with the trial that was presented, is that there doesn't seem to be enough emphasis on selecting your patients who you're not going to operate on. And and I think we have to be very cautious in pushing patients into triple modality treatment with all the swallowing and the other concerns around that.
That's brilliant. Thank you. Thank you very much for the panelists. And we'll be back in 11:45 after a coffee. Thank you very much, Niclas, and all the panelists.
Thank you.